Dear friends, let us discuss about the strain in echocardiography. Now, strain in echocardiography is quite matured because it is there around for almost 15 years. We want to understand the myocardium, and the ways to understand the myocardium is the strain imaging, the T1 values, the extracellular maps, and the replacement fibrosis by the LGE. Now, the strain tells you about the deformation characteristics of the myocardium, which get affected by the interstitial fibrosis or replacement fibrosis. One thing we should know is that the myocardium is arranged in the helical fibers in the helical way. So the subendocardial fibers are arranged in a right hand helix, and these subendocardial fibers are needed for the longitudinal contraction. So therefore, the global longitudinal strain is more affected by the subendocardial helical fibers. Now, this is how the global longitudinal strain looks on echocardiography. You get a polar map and you get a global value. The same thing can be displayed as the time and strain map for each of this segment. Similarly, if you have a 3D data set of the echocardiography, then you can have the global longitudinal strain, the global circumferential strain, and the global radial strain, all measurements done with a single set of 3D data set. Similarly, when you have a short axis view, you can measure the radial strain and also the circumferential strain. And this short axis view is also useful for the rotational characteristics of the left ventricle. Now, these are the normal values of the global longitudinal strain on the echocardiography, which is around -20. The circumferential strain can range from 24 to 28. The radial strain has got a tremendous variability, and it's not so well standardized. Let us look at certain cases. So, this is a 72-year-old lady who is a diabetic. She had a past history of paroxysmal atrial fibrillation. She is obese. She has class 2 dyspnea. Now she is a regular patient of any cardiology OPD. Now echo looks fine. There is a nice contractility of the ventricle. There is no regional wall motion abnormality. The EF is definitely normal. Look at the short axis view, perfectly fine. But just look at the global longitudinal strain. It is -14.6. That means this lady, despite having a normal ejection fraction and being almost asymptomatic, she already has started developing subclinical cardiomyopathy. And her global longitudinal strain has significantly dropped, which is -14, almost a 6% point drop. Now, this global longitudinal strain is more sensitive marker of a preclinical LV dysfunction. It predates the fall of the left ventricular ejection fraction, and it also predicts the LV remodeling, future admissions for heart failure, and also mortality. Let us look at this lady's RV function. The right ventricle looks perfectly fine, contracting well, and so also the Doppler, tissue Doppler of the tricuspid annulus. However, let us look at her strain of the RV free wall. And this is actually quite compromised. It is -18. Generally, the RV free wall strain would be in the range of 24-25. So the thing is that is how this strain is useful for picking up a subclinical disease. Let us look at this gentleman, 32-year-old male, who has a very good physical effort capacity, but he is diagnosed with Hodgkin's disease, and he has Hodgkin's lymphoma, and he's on a adriamycin containing regime. So, so this is in September. We have this echocardiogram. The EF is perfectly fine, and the GL is -20. Now he, over the next 2 months, he receives the 2 cycles, and we see him at 10th November. And let us look at the 2D images. The ejection fraction looks perfectly fine, but what has happened to the GLS? The GLS is -15%, so there is a 5% point fall in the GLS. Now, this is early cardiomyopathy produced by adriamycin. So the thing is, the longitudinal studies have shown that a longitudinal strain fall of more than 10% actually predicts the future fall of LV ejection fraction almost 6 months before. Now, this is the data from the same study. The red bars indicate the fall in the GLS after starting atreomycin, and the blue bars show you the fall in the ejection fraction. As you can see that at 8 months point, there is a significant drop in ejection fraction, but this was predated by the fall in the GLS just at the 4 months data set. So the fall in the GLS always tells you about the future fall in the ejection fraction and can alert you of the adriamycin induced cardiomyopathy so that you can start the ACE inhibitors, beta blockers, spironolactone. Let us look at another case. This is a 63-year-old male presented to the emergency department with atypical chest pain. He is a diabetic, non-hypertensive, non-smoker. Now, always in the emergency room, when you see an ECG which is normal, you generally take an echo and look for a regional wall motion abnormality. Now, looking at the regional wall motion abnormality, I don't think there is any regional wall motion abnormality. The LV is contracting well. There is no regional akinesia. So let us see how these patients are managed. Generally, when you are suspecting an acute ischemia, you are looking for a myocardial necrosis. So you send troponins. The troponins are generally available within 1 hour from the lab. But the same thing, the ischemia also affects your subendocardial fiber. So there is a subendocardial contractile dysfunction and which can be picked up by the strain imaging. So let us look at this patient's strain and we can easily see that the apical segments do not show a good strain values. The strain values which are in this particular region of blue shows that these strains are terribly low, while the red ones tell you that this is a normal strain. So we already know that there is a left anterior descending territory segments showing a very low strain. So this patient's bull's eye already shows you a hole at the apex. And let us look at his angio. You can see a very critical left anterior descending artery there. At the same time, obviously, he also has multivessel disease, but probably the LED was the culprit for the patient's angina. Let's look at this case. He's a 54-year-old doctor. He was actually a dentist, non-diabetic, non-hypertensive. His CT coronary angio was done 2 years back, which was perfectly normal. He had chest pain on exertion. He had a normal resting ECG. So he was turned on twice from the cardiologist's office. So this is his echo when he climbed one flight of staircase to our echo lab, and you don't find any regional wall motion abnormality here. Let us turn on the strain in this particular patient. The moment you turn the strain on here, let us look at the segments at the apex and let us look at their strain time graphs. So you can see that these segments, the apical segments, show a post-systolic shortening. You can see this green graph here. So this is the aortic wall closure, and after the closure, there is a continued contraction of the apical segments. This post-systolic shortening is generally associated with either a repetitive stunning or a very significant resting ischemia. And the same thing is, if you look at the bull's eye of his strain, you can see that there's a reduced strain at the apex. And let us look at his angio, and you can see that there is a very, very significant proximal LED disease. So the thing is, the strain has always been used even for the viability assessment. Now, if you look at this segment number one, which is normal, segment number two, which has recovered after revascularization, and segment number three, which are the segments which have not recovered after revascularization, you can see that the post-systolic strain or the global longitudinal strains continues to reduce from the normal segments to the segments which are not recovered after revascularization. So that is how it can even predict viability to a certain extent. In another study, what they looked at was the myocardial enhancement. Now, the patients with a transmyocardial enhancement less than 50% versus more than 50%. If you look at the global longitudinal strain in the segments which did not have microvascular obstruction versus the segments which are shown by red where there is a microvascular obstruction. You can see that consistently the segments with microvascular obstruction show a further reduction in the strain as compared to the other infarcted segments. Let us look at the role of strain in CRT. Now we'll look at this 38-year-old lady who has a peripartum cardiomyopathy. She has a left bundle branch block, EF of 15%. She had a CRT implantation and she actually became a super responder. Her EF improved to 50-55%, and she had a LV reverse remodeling. Now these are the leads. This is the lead in the right atrium. This is the lead in the right ventricle, and this is the lead with through the coronary sinus has gone into the left ventricular epicardial surface. Now, this lady has come for the CRT evaluation, and what we did was we just turned the CRT off. We looked at her echo. Okay, it's okay. It shows a little borderline LV function. We turned the CRT on. Visually, I don't think we could make out any difference. But let us look at the strain curves of this lady. When the CRT is off, we are looking at the strain at the LV short axis, and you can see that both all these segments are picking at different intervals at different time intervals. So there is a complete chaos. Okay, there is complete dysynchrony. The moment we turn the CRT on, you can see that all the segments are now contracting at the same time and they are reaching their peak strain almost at the same time point. Okay, so that is how the CRT works. Now, this is the same thing for her longitudinal strain. When the CRT is off, you can see that different segments are having their peak strain at different time points. The moment we turn the CRT on, all of them are now peaking at the same time. Okay, so this is how all the segments have got recruited by the CRT. So the CRT, let us look whether the CRT works permanently. We'll look at the case number 2. This is a 66-year-old gentleman, dilated cardiomyopathy, diabetic, and he had 2 hospital admission with decompensation. He is optimal medical therapy and he has a LBBB. So with a QRS duration of 150. So this is how his LV is. Very poor LV, hardly some 15% ejection fraction. Let us look at the strain, radial strain of the LV short axis, and you can see that various segments are picking at various different time points. So there is a complete chaos of contractility of various left ventricular segments. Now this patient goes for a CRT. So what we do is that we are looking at the LAO view, which is just like looking at the LV short axis. Okay, and we know which is the latest activating segment. Now, if this is how the coronary sinus will be located, and these are the tributaries. So this latest activating segment with a particular tributary, if you can target it by your LV lead, nothing like it, because then you will be stimulating the latest activating segment. So this is how the lead is positioned in this patient. And as we knew that the lateral segments were the ones which were contracting the latest. So 4 months after, you can see there is an improvement in the LV ejection fraction, and not only that, if you look now at the strain curves, most of the strains are now peaking at the same time. So there's a significant amount of synchronization. Now, this is after 22 months. The patient has again gone into heart failure. The LV is again dropped down. And let us look at the short axis. You can see that some of the segments are contracting while some of the segments are getting stretched. This is we call as CRT fatigue. That means now the CRT no more works. Now, this is because of the progression of fibrosis in various segments of the myocardium. That is why all those synchronized segments are now again has got desynchronized because of the progress of myopathy. Now let us look another case. This is a 52-year-old male, asymptomatic, and he's known case of hypertrophic cardiomyopathy. His family, there is a history of sudden cardiac death. Now this is his echo, a very classical echo with an asymmetric septal hypertrophy and a SAM. And this is his short axis showing an asymmetric septal hypertrophy, which is quite significant along with hypertrophy of the apex. These are the CMR images of the same patient showing you the same distribution of hypertrophy. Now let us look at this strain map. Now very interestingly, the most hypertrophied segments are actually not showing good strain. Rather, this is shown this shows variable strain. That means some areas are actually getting stretched, some of them are getting compressed. So this is the most hypertrophied area is actually showing the worst strains and which are also having very it takes a variable color shades. So it's the same thing. So if you look at the polar map, the segments, that is the septum and the anterior wall, or was the one which had got the significant hypertrophy, is actually showing very poor strains because these areas actually have a lot of interstitial fibrosis. So that is why they are showing a very poor strain. And the same thing you can see it on the LGs, that the septum is the most affected area with a very significant fibrosis, and that is why it has got the worst deformation which was seen on those polar maps. Now let us look at the torsion of this patient. This is the basal LV short axis, and you can see this is the basal rotation. Now this you can also achieve because of the strain imaging, because you can measure how many degrees it is rotating. So this is the basal rotation, which is generally in the clockwise rotation, and this is the LV apex, and you can measure its anti-clockwise rotation, and this is this anti-clockwise rotation. So the base rotates clockwise, apex rotates anti-clockwise, and that is how the LV produces torsion. And the whole torsion also you can measure, and you can see that this LV is rejecting only by twisting because it hardly has any good radial or longitudinal strain. Now let us look at this 41-year-old male who has a progressive dyspnea class 3. Here he has detected cardiomegaly and LVH. His two brothers have been diagnosed with very hypertrophic cardiomyopathy, and this is how his echo looks. A very severe hypertrophy, hardly any longitudinal contraction, but this hypertrophy looks little different than what we saw for the hypertrophic cardiomyopathy patient. And when we look at this patient's global longitudinal map, you can see that at the apex, the strains are preserved, while rest of the places, the strain has gone significantly down. This is called as the cherry on top ice cream cone, and this is supposed to be very characteristic of amyloidosis. So this is the cherry on top kind of a GLS map. And you can see that he has got a very reduced basal rotation, very big reduced apical rotation, and a very reduced LV twist. And this is the CMR images of the same patient showing you the hypertrophy and reduced longitudinal contraction. And the moment you look at the LG, you would see that the base and the mid segments are having very significant transmural LG, while the apex is having just a subendocardial LG. And that shows you why there is an apical preservation of the strain, while the strain had significantly reduced in the mid and basal segments. And this is the technician pyrophosphate scan of the patient showing extreme uptake. Now let us look at this 52-year-old male who is hypertensive, completely asymptomatic, BP 140/90, and he is known case of severe calcific aortic stenosis. Now he has got a nice LV function. He's perfectly asymptomatic. He goes for hiking, and these are his gradients. These gradients are quite significant, but he's like an asymptomatic severe aortic stenosis, which on clinical grounds you would like to conserve. His ejection fraction is 52%, gradients are 74 by 45. But look at the global longitudinal strain, and you can see that the global longitudinal strain is significantly reduced, and it is just minus 12%. So this patient, though he is asymptomatic, his hypertrophy has started becoming pathological. He has started developing interstitial fibrosis. This is the time when they should be going for actually aortic wall replacement, and this is one of the suggested plot by Dr. Marvik, and it says that if the patient's ejection fraction is above 55%, just look at the GLS. If the GLS is more than minus 18%, you follow them up every 1 to 2 yearly. If the GLS is between minus 16 to 18, follow them 6 monthly. If the GLS has dropped below minus 16 in these patients with severe aortic stenosis, look at their T1 and ECV. If they are abnormal, better consider an aortic wall replacement. We'll look at another case, a 44-year-old lady, class 2 dyspnea. She's operated for ASD. She has a residual pH and she has got a severe mitral regurgitation. Now she has got significant mitral regurgitation, as you can see from the echo images. And this is the PISA showing the proximal isosurface velocity surface area, which is quite big. And this MR is definitely severe. And one can even quantify them. The same patient being quantified by cardiac MRI. You can see the stroke volume by the volumetric method is 70 ml. And at the same time, you take the aortic stroke volume by the phase contrast images. So you get a regurgitant volume of 30 and a regurgitant fraction of 40%, which is definitely a moderately severe mitral regurgitation. Now, she has got a normal ejection fraction and she's asymptomatic. Then why do you worry? But let us look at her strain. And you can see that her strain is minus 19. You would say, okay, minus 20 is normal, minus 19, I'm not worried. But in mitral regurgitation, LV is facing a large preload and a very low afterload. So the LV should be hypercontractile. So the MR patients have GLS values of minus 22, minus 24. A GLS of minus 19 tells you that already the LV systolic dysfunction has set in. I will make a quick reference to left atrial strain. Now, this is another frontier which MR is definitely going to conquer. The left atrial strain is shown by this particular graph. So, during systole, you have got the reservoir strain when the LA expands. Then, early diastole, you have got a conduit strain when the LA reduces in size, and when the atria contracts, you have a booster strain. So, there are three patterns of left atrial strain. And you can also look at the strains of various segments of left atrium, whether they have got any dispersion. So I will show you the use of it. It is a 60-year-old lady, hypertensive, normal sinus rhythm. In July 2013, we saw her. She looked okay, fine. Ejection fraction was fine. The GLS was minus 20, so everything looked fine. Now, in December 2014, that is almost after 19 months, she comes with a stroke and an atrial fibrillation. You can see the atrial fibrillation there. We look at the transesophageal echo and there is no LA clot. Okay, so this lady has just developed atrial fibrillation, and that's why probably she developed an LA clot and she came with a devastating stroke. Could we have predicted this atrial fibrillation in 1 year before? So let us look at her echo 17 months back. This was his echo 17 months back. Look at her left atrium. And we'll measure the strain, and the strain is hardly 11%. Normal LS strains are 40%. So she not only had a very significant reduction in the LA strain, but also there was a significant dispersion in the LA segmental strains. So she already had developed an atrial cardiomyopathy, and she was actually had a substrate to develop atrial fibrillation in future and develop stroke. So LS strain can predict a future atrial fibrillation. Now, this is a 75-year-old lady, hypertensive, normal sinus rhythm. She was hospitalized 1 year back with LVF and paroxysmal atrial fibrillation. So, this was her paroxysmal atrial fibrillation, and she just got spontaneously converted to normal sinus rhythm. And she was in heart failure with normal ejection fraction. However, over this 1 year, she had a worsening exercise capacity. Her GLS is perfectly fine, but let us look at her left atrium. Her left atrium is not only enlarged, but her strain is hardly 10%. Okay, so this lady is already in heart failure with preserved ejection fraction, but her left atrium tells you the story that she is in heart failure, and not only that, she has got a higher incidence of developing paroxysmal atrial fibrillation and strokes. So, ladies and gentlemen, let me touch to the future. Now, I have taken this CMR image, and you can see that the apex and the base doesn't move because the base is attached to the pulmonary veins, and the apex is fixed here at the near the sternum. So, what goes up and down is only your mitral annulus. So, you have got a piston-like motion of the mitral annulus. So when LV reduces in volume, LA increases in volume, and vice versa. Now the whole thing, you can look at the LA-LV as a single complex and can take a strain of the entire LA and LV. And this is very interesting because this encodes a lot of things. If you know you can track the entire and LA and LV, you can actually see the rate of change of volume during systole and diastole. So if you take this cardiac cycle, the ventricular volume and the atrial volume, the rate of change of volume you can actually plot from this. And this is nothing but the mitral Doppler flows of early diastolic flow and the atrial systolic flow. Same thing, if I can just look at the rate of change of strain of the entire left atrium and left ventricle, then throughout the cardiac systole, I can monitor the left ventricular rate of change of strain and so also the left atrial rate of change of strain, and this is nothing but the tissue Doppler of the mitral annulus. So we have that entire information here for a diastolic function assessment, and MR can do a lot of progress into this. So this will be a single step, single bit multi-chamber, fast and fully automated and Doppler free on operator independent way of finding of diastolic dysfunction on just cardiac MRI images. Thank you.